Physiowebseries Shoulder Complex Season 2. Let's begin with Series 1. So here we will discuss about shoulder girdle muscles along with their insertion, origin, insertion, action and nerve supply, including the clinical aspect wherever necessary. So in Series 1, we will focus or discuss about supraspinatus muscle, which is a part of rotator cuff of the shoulder joint. So supraspinatus muscle, as we know, it originates from medial 2/3 of supraspinous fossa, traverses laterally beneath this coracoacromial arch, can be appreciated in this one anterior view and over here this posterior view. So traverses this way laterally beneath this coracoacromial arch to insert on the upper impression of greater tubercle. So while inserting, it goes to blend with the capsule of the shoulder joint. So this was about origin and insertion of the supraspinatus muscle. The fact that the supraspinatus muscle passes laterally beneath the coracoacromial arch is of clinical importance, as this will be responsible for shoulder impingement or subacromial impingement syndrome, which will be discussed later in this series. Apart from origin insertion, coming to nerve supply, so can be appreciated in this diagram that the suprascapular nerve traverses this way to supply the supraspinatus muscle. So suprascapular nerve from C5, C6 nerve root of upper trunk of brachial plexus supplies this supraspinatus muscle and goes down to innervate the infraspinatus as well. So focusing on supraspinatus, it is innervated by suprascapular nerve. Let's see about the action of the supraspinatus. The role of supraspinatus is crucial in shoulder abduction. So its action as the abductor of shoulder joint from 0 to 15 degrees is debatable or controversial as proven by some studies, yet it is considered that it is recruited in 0 to 15 degrees of shoulder abduction. Along with deltoid, this supraspinatus muscle is involved in initiation and continuation of shoulder abduction. So from 0 to 15 degrees in initiation, the supraspinatus muscle is working, and apart from that, beyond this range, along with deltoid, also it is working to maintain the continuation of abduction. But apart from this initiation of abduction or its continuation ahead, the major role of supraspinatus is also to steady the head of humerus, to position the head of humerus properly into the glenoid fossa while the shoulder abduction movement is performed. So, as the humerus will abduct, the supraspinatus will work to steady the humerus into the glenoid fossa. So, in this diagram, in the middle diagram, the second diagram, can be appreciated the forces. So supraspinatus is situated somewhere like this. The force, if we can see the third diagram, we know the origin as well as the insertion of the supraspinatus muscle. Now coming back to this diagram, second diagram, the force exerted thus by the supraspinatus, as this is the medial part and this will be the lateral outside part. So the supraspinatus will exert force this way, in this direction, so that it pulls the humerus up and we can perform the desired shoulder abduction movement. So supraspinatus will exert force this way, which can be appreciated properly in this diagram. Now the deltoid as considered over here along with the supraspinatus, we know that it works in continuation of abduction. The middle fibers of deltoid will be responsible for shoulder abduction beyond 15 degrees, majorly. So the supraspinatus is recruited as it has to stabilize or steady the head of humerus into the glenoid fossa. And this supraspinatus muscle, as it is pulling the head of the humerus or the humerus this way, exerting force on it this way, so that this humerus is pulled upwards, causing shoulder abduction. This supraspinatus, along with it also prevents this excessive upward or superior translation of the humerus. As the deltoid is doing majority of work in shoulder abduction, it is causing greater force so that shoulder is pulled upward. That is, it can cause abduction, shoulder abduction with greater amount of force if we consider the deltoid muscle. So there should be something which will stabilize the humeral head into the glenoid fossa throughout the range of motion, so that this humeral head will not go up and stuck into the subacromial space, causing impingement syndrome. As we know, from that subacromial space lies the subacromial bursa as well as the supraspinatus tendon, which is going beneath the coracoacromial arch to insert on upper impression of greater tubercle over here. In this third diagram can be appreciated. So to prevent that, supraspinatus is working to steady the humeral head in the glenoid fossa and to prevent this excessive upward translation of humerus, which can be caused by deltoid if it is working alone. In case of injury of supraspinatus, where deltoid will exert its entire force on shoulder while performing shoulder abduction, and there is no stability provided by supraspinatus in doing so, and hence the soft tissues in between the, like beneath the coracoacromial arch, will get impinged or trapped, and the patient might complain of pain and weakness, pain at the upper anterior portion of the shoulder joint, and weakness while performing the shoulder abduction. So this part, the action and how the biomechanics is getting affected in the absence of supraspinatus muscle, is to be understood very clearly. So again, we should remember that the role of supraspinatus in steadying the head of humerus during shoulder abduction is very much important, along with its action of initiating the abduction as well as being recruited in continuation of abduction of shoulder joint. Now we physiotherapists have a key as special test to be performed on patients to come to the root cause of certain pathologies. So if there is pain and weakness of the supraspinatus muscle while performing abduction, there might be some problem with supraspinatus muscle. The tendon might get trapped, or there may be partial or complete tear of supraspinatus. So to come to a conclusion that there is some problem for sure, we can perform a test called as empty can test. Empty can test, as the name suggests, the action in the diagram is mimicking as if one is trying to empty the can full of water. So in that position, the shoulder is abducted to 90 degrees and medially rotated, that is thumbs down, medially rotated or internally rotated. And this black arrow over here is the resistance applied by the therapist on the patient, and the patient is asked to perform the abduction movement, which is indicated by this blue arrow. So patient is asked to perform abduction against the resistance applied by therapist. And while doing so, if there is pain and weakness in the region specified here, over here, somewhere over here where the supraspinatus is getting impinged, so if there is pain, weakness while performing this, then the test is considered to be positive that there is some pathology of supraspinatus over here. So to understand the supraspinatus pathology in detail, let's see this. Now, as we know, the origin of supraspinatus from the supraspinous fossa traversing laterally beneath this coracoacromial arch to insert to the upper impression of greater tubercle. This is in posterior view, and over here is the anterior view. So we can see here it is inserting to this greater tubercle, and there is this subacromial space, acromion process. There is this subacromial space where also the bursa is lying and the tendon is passing beneath it. So if the supraspinatus is not working properly, if there is some pathology or lesion to the supraspinatus, then the deltoid will act during shoulder abduction and it might cause this humeral head to translate upwards this way and get trapped in this space, giving rise to symptoms of pain and weakness of this region of shoulder joint, or the involvement of supraspinatus tendon or muscle in this space. So here we can see this is the normal joint where the shoulder abduction is performed and there is enough space beneath the acromion process so that supraspinatus is working properly, so that there is no excessive upward translation of humeral head to cause further impingement. But if there is compression or impingement and one is trying to perform shoulder abduction or performing the shoulder abduction, then there will be compression, further compression and impingement of the soft tissues. It can be bursa, subacromial bursa, as well as the supraspinatus tendon passing from here. So this is a syndrome because of repetitive compression or impingement of this rotator cuff tendons, mainly the supraspinatus tendon, which will aggravate with those overhead movement of the shoulder joint. So now let's try to distinguish between something called as painful arc syndrome or the painful arc between the range 60 to 120 degrees and another thing which is the supraspinatus tendon tear, how to come to a conclusion. That is by testing the range from 0 to 20 degrees. So coming to subacromial impingement syndrome, we can see the narrowed space and there is impingement of the supraspinatus muscle or tendon passing beneath this coracoacromial arch. So if there is impingement, then overhead movements will cause pain and weakness, mainly the pain, hence it is called as the painful arc. So this subacromial impingement syndrome, considered a painful arc syndrome between 60 to 120 degrees of shoulder abduction. So this painful arc, if present in a patient, then the conclusion goes to subacromial impingement. So in this case, there is the bursa, subacromial bursa, the supraspinatus muscle and its tendon passing, which is getting entrapped between those bony parts. So these soft tissues are getting entrapped, causing inflammation, giving rise to pain. So this painful arc 60 to 120 degrees is for subacromial impingement. Whereas if there is supraspinatus tendon tear, how we will come to know? The patient with complete tear or maybe partial tear will have difficulty even in initiating the shoulder abduction, as the supraspinatus has its action to perform 0 to 15 degrees or 20 degrees might be considered. So that much 0 to 15 degrees of shoulder abduction. So if there is weakness or there is tear of the supraspinatus, then it is obvious that the muscle will not work at its 100% efficiency, which is initiation of abduction. So the patient will not be able to do initiation of abduction in supraspinatus tear. So if there is complete tear, then the patient will not be able to perform abduction, not able to start the abduction movement, which is 0 to 15 degrees. So we will come to know that it is supraspinatus tear. Also, if there is repetitive micro trauma, like initially there is impingement syndromes due to narrowing of the space, due to impaired biomechanics of shoulder, due to the slouched position, slouched posture, there may be impingement, narrowing of the space, which is aggravated by overhead activities, and this repeated micro trauma along with some other pathology can cause partial tear. So repeated micro trauma may lead to partial tear of the muscle, as well as if there is history of fall or any other trauma may lead to complete tear of the muscle. But for the complete tear, there should be certain amount of force applied which might be responsible for the complete tear of muscle. So we now come to know how to distinguish between the painful arc syndrome the shoulder impingement, subacromial impingement syndrome, which is between 60 to 120 degrees of a shoulder abduction, and how to distinguish it from supraspinatus tear. So this was about supraspinatus muscles along with its origin, insertion, nerve supply, and its action, which is very important to understand, and the clinical aspect involving the impingement syndrome or the supraspinatus tear.